just let me know when to switch those slides.
Hello, and welcome to YP Speaks. I'm Jordan Jarvis, the Executive Director of the Young Professionals Chronic Disease Network, and we host YP Speaks on a regular basis to engage a discussion and hear presentations from people within our community worldwide related to NCDs. And so today is an exciting session. We have David Barros, Dr. David Barros with us from the Mexican Health Foundation. And so myself, I'm also based at or YPCDN is based at the Harvard Global Equity Initiative, and HGI works closely with the Mexican Health Foundation. And so it's great to have someone from the group joining us today, and especially David, to hear about NCDs in a humanitarian setting, because it is something that we don't hear much about, and we definitely need a lot more discussion on. So David actually trained at Harvard University in public health and has done some work with MSF over the past little while, working in South Sudan as a supervisor of therapeutic feeding center and pediatric surgery ward, and recently in Lebanon, where he supervised primary health services for vulnerable Lebanese caught in a cycle of sectarian violence and Syrian refugees through a pilot program on NCD care. So now he's the project coordinator for the Department of Universality and Competitiveness in Health at the Mexican Health Foundation. Without further ado, I'll hand it off to David to tell us about his work.
Thank you very much, Jordan, and it's thank you for inviting me. It's very exciting to be here, and what you say is true. You know, the NCD world has usually been set apart from the humanitarian action. Each group felt that the other was kind of out of their core competencies, but more and more so, we're looking at a global context where these two worlds are colliding, and some of the biggest NGOs out there, medical NGOs out there, are beginning to take action. And MSF, I'm proud to say, is one of the first in doing so. And I had that experience working with them, with the Syrian refugees living in Lebanon, implementing their pilot study pilot program for NCDs with this population. So I'm very excited to share that experience with everyone, and I'm going to jump to the slides now. Let's see.
While you do that, maybe I'll just get Chris, if you can introduce yourself as well. I sort of completely jumped over that, and
sorry, yeah.
We have a discussion going here.
No worries. I'm Chris Ronson. I am a fellow YPer, love YPCDN, and also with the Speak in Global Health. I work in nutrition and sort of in a humanitarian context as well. So I'm really, I can see my own face, really excited to be here to listen to David or Dr. Barros talk about this issue, because I think it's something that's becoming increasingly relevant with this escalation of conflict as well as the double burden of disease that we're seeing globally. So this is a very timely show. Thank you, YPCDN, for bringing it to everybody.
Okay, perfect. So Jordan, should I go ahead then?
Yep.
All right. So 1 second. There we go. Is the presentation on? I guess is everybody able to see it?
You are good.
All right. So the idea behind the presentation, while I was trying to set this up, is to kind of give you an overview of the process, of the thought process of the considerations that MSF had to take part on to actually intervene on an NCD program for Syrian refugees. So first, we're going to give a brief overview, and I don't want to preach to the choir, but I think it's just important to set the context on how NCDs are looking at the global perspective. I'm not going to take much time in this, because I think most of you will know, or maybe all of you will know what's the current situation. Then I'm going to talk a little bit about why is it important to take care of NCDs, to focus on NCDs in the humanitarian context. I'm going to talk a little bit about how the humanitarian crisis in Syria looks like, and why is it important in Lebanon. Why is Lebanon so important for this crisis? And then we're going to go straight ahead to a little bit of a case study of MSF, of Doctors Without Borders, and my experience working with them. And then we're going to review a few of the obstacles and challenges that that we encountered over there, and hopefully we can finish up with some things that might be able to change, some goals to set for the future in humanitarian action. So I'm gonna just jump in. So as we know, I mean, NCDs are the first cause of death at the global level. More and more so, it's not only a group of diseases that afflict the elderly, and more young people are suffering from it. And what I really want to focus on here is that most of the deaths occur in low and middle income countries, and this is very relevant for humanitarian action, because humanitarian action it just happens to be much more. It happens much more often in low and middle income countries. So you have this synergic effect from having a high burden in low and middle income countries from NCDs, and high incidence of humanitarian emergencies in low and middle income countries. And precisely these are the countries that are more vulnerable to have the emergencies, being man-made or natural, and they're also the least prepared to respond. They usually have weak health systems, and the consequences of these two effects are usually pretty dire. So, like I was saying, these people, people living in low and middle income countries, will be more vulnerable to emergencies. But people living with NCDs in these countries are even more vulnerable during emergencies. And why is that? That's because they require chronic and continuous medical treatment. And one of the first things that happen during an emergency is, health services are shut down or are shifted towards more of an acute perspective, dealing with acute emergencies. And it's usually been the norm that the chronic side of the issues are left on a second kind of level, of less importance. We know that patients living with NCDs will have a higher incidence of acute complications and long-term complications arising from the interruption of these services. For example, it's not only my experience, but in other places, and I will give you a few examples. You can see that if you have an armed conflict going on, you don't have access to your insulin or to your chronic medications for diabetes. You're bound to have a higher blood sugar, and with that, complications such as infection of the foot, and even chronic complications such as amputations. And you can see in the picture, for example, here we have this was a young gentleman that was shot by a sniper, and actually the bullet being used in this case was one with little steel pellets inside it, and so what happened was he got an infection, a chronic infection, because those pellets were unable to drain. And imagine what would happen if this man had diabetes or something else that would limit the healing capacity and would put him on a risk of infection. He might as well have ended up with an amputation of the feet. So this is one of the chronic complications and the long-term complications that may arise from even a short or temporary interruption of treatment. Now, like I was saying, is there any evidence that NCDs are actually exacerbated during emergencies? And to be honest, there's not much. One of the reasons why there isn't much evidence is that it's precisely because humanitarian emergencies usually happen in these weak health systems that don't have the best monitoring and surveillance systems in place. So it's hard to assess the impact. Nevertheless, we do know from experiences in Kobe 95 in Japan, as well as in other, like in Katrina in 2005, that there are actually acute complications arising, such as measurable increases in HbA1c, measurable increases in in blood pressure. There is an acute increase in the incidence of mental health complications, such as acute depression, anxiety, and others. And other things that have been seen is an increased incidence in asthma exacerbations. But that's not, we have seen effects not only on the side of complications, but also on the kind of services that people are actually trying to be provided with. In Katrina in 2005, we know that during the emergencies, immediately after the emergencies, almost 70% of all medicine sold was actually for NCDs. So only 30% was actually medication being sold to treat acute complications arising from trauma, and other things that would be more in the medical frame, what we would think would be more likely to be seen in an acute natural emergency. And these usually, and these numbers are actually taken from private pharmacies. So we're looking at people that having to buy private medication, having to take out-of-pocket expenditures to actually pay for their chronic medication. And precisely one of the reasons why is that the NCDs medications are not usually integrated into emergency kits, right? And some other things that we're seeing that are very interesting is that almost 20% of the people who had NCDs actually had to interrupt their treatment, either temporary for a short period or long term. So we do know that there is some evidence that NCDs are exacerbated by emergencies. But these examples are coming from high-income countries usually. We don't have much information from low-income countries, and that's a problem. So, like, why focusing emergency? Why create a pilot program, or why intervene on NCDs in the humanitarian context? I think there's like I said, there's variable evidence to point towards this need, and all of these effects have a synergistic effect, a deleterious effect. You have a higher NCD incidence in low and middle income countries, precisely where are more likely to have natural and man-made emergencies. You have a poverty in these countries, and poverty in itself will limit the capacity for the system to respond to NCDs and to emergencies, and we have these situations, these emergencies, and these epidemiological kind of context, also in countries with weak health systems, and health systems that are less likely to respond adequately and completely be able to respond to an emergency, and even less so to the NCDs. So this is sorry, a little bit of an effect. Okay, so this is one of the reasons why MSF started thinking about intervening on NCDs during a humanitarian crisis. But why the Middle East, and why specifically Syrian refugees? And just a little bit of background about Syria and the refugees. We actually currently there hasn't been as many refugees right now since the end of the Second World War, and I think that's pretty scary, and it's a number that really drives attention. It's just huge, the burden, the number of people living in a refugee state. In 2013, it was almost 42 million people who were either refugees or internally displaced. And most of the IDPs at least, come from only 5 countries. And one of the highest now is Syria, along with Colombia, Congo, Sudan, and Nigeria. And again, in 2013, there were almost 15.2 million refugees. And at that time, there were 3 million Syrian refugees. Nevertheless, by the end of 2015, the UNHCR expects that even upwards of 4.3 million refugees will have fled from Syria. So this is a staggering number, but why Lebanon, right? I'm gonna come back to this issue on why is it a problem with Lebanon, and just a further in a couple more slides. But first, I also want to bring attention to the fact that the Middle East is an area that has the highest diabetes prevalence in the world. It's almost 11%. Obesity, one of the primary risk factors for diabetes, is 3 times as high in women than in men. And this is not usually a profile that you see in other countries. It's pretty specific to the Middle East. And almost 55% of all adults suffer from NCD. So this is quite staggering numbers, I believe. And now moving on to Syria. Syria before the crisis had actually a pretty good health system. They enjoyed having a middle income. They enjoyed having an economic state of a middle income country. They had what you could consider a strong health system. People were being taken care of, and their epidemiological profile was as heavily cited to the NCDs. Almost 70% of their mortality was due to NCDs. And what we know now about Syria is it's all estimates, really. I mean, Syria has since 4 years ago, since the civil war started, it's been a little bit of a black hole of information, of communication. It's very difficult to get inside information, primarily because of very few NGOs are actually allowed inside the country. But what we do know is what we see in countries actually accepting a large amount of refugees. One of them is Lebanon, and these numbers are actually from Syrian refugees in Lebanon. We know that 45% of all NCDs in Syria and Lebanon are cardiovascular disease. We don't know exactly the mortality rates of NCDs because there's a lot of influx and flux of people coming back and forth from Syria to Lebanon and to other countries. We know that 50% of the Syrian population living in Lebanon require mental health services. And this is not really, this should come as a surprise. I mean, these are people coming from highly violent context, and in my experience, they usually have post-traumatic stress disorder, high degree of depression, and other things we can review later on. Almost 50% of all the Syrian refugees living in Lebanon will require NCD interventions. From the 220,000 Syrians that have died during the conflict, even though we don't know what's the actual toll for NCDs, we do know that that NCDs and the lack of access to NCD care is making quite an impact. So why this is kind of the background on why MSF started acting or started thinking about implementing a pilot program for Syrian refugees. And why in Lebanon? Well, Lebanon is a country with 4.5 million people that in less than 3 years, they had an influx of about 1 million people. By the end of 2005, it's going to be almost 1.5 million people. So imagine, I mean, for example, Mexico has about 120 million people, and I just thinking about the context here, if in about 3 years we had an influx of 40 million people, well, that would certainly put a strain on the health system, and in any health system. So the Lebanese health system is completely unable to deal with this magnitude of a burden, and this is why UNHCR is acting in the area, and why it's very important for NGOs working in humanitarian emergencies have to intervene. MSF's activities in Lebanon are mainly concentrated in 3 areas. One of them is Tripoli, where I was working, which is in the northern side. The other part is the Bekaa Valley, which is sharing a border with Syria. The headquarters are in Beirut, but there isn't quite a lot of activity, of medical activity there. And the other side is in Saida or Sidon at the south. In 2013, and I wish I had the numbers for 2014, but I could only get for 2013. And by the way, I just want to mention that the efforts have increased. So maybe if you ask me again in 1 more year, once we get the complete numbers for 2014, this will be a little bit different. But it's still quite a big intervention. 114 medical consults in 2013, 17,900 only for NCDs. And the kind of activities that the MSF are actually partaking here are primarily in the primary healthcare level. It's more of a structural approach. We're training people, and we're going to get a little bit more into that, into those details. It's responding to sectarian violence, primarily in Tripoli, and that was one of my core responsibilities in Tripoli. Setting up emergency preparedness kits for Tripoli and for Saida and for the Bekaa Valley. And what we're going to center now, it's on their NCD pilot program. And this NCD pilot program that MSF has implemented, it is also being implemented in Iraq, and and I believe this year they will start doing the same in Yemen. So they have seen certain success with it, and they plan to expand these activities. And I think that's good news for the humanitarian aid. Now, concerning the pilot NCD program, we were focusing primarily on secondary and tertiary prevention. Why is it? The idea behind it was, okay, we have a large Syrian population, a refugee population. We can't really intervene in primary prevention. That's a little bit, it would seem, out of the capacity for MSF. But we can provide medication, we can provide secondary prevention and tertiary prevention for what would be the highest burden, which comes primarily from diabetes, hypertension, and cardiovascular diseases. But we actually expanded to cover asthma, epilepsy. We had very few patients with hypothyroidism, and of course mental health. And the mental health program was almost seen as a different program than the NCD, but it was implemented in the same kind of circumstances, and I believe there is a lot of the same kind of structures that have to be set up to actually have a successful program for mental health as with NCDs. In Tripoli, where I was working with, we're working in the Dar al-Sara hospital, DAS hospital in this case. We had over 2,000 active patients in the program, and our doctors were seeing almost from 80 to 100 consults per day, and we're seeing mostly hypertension. That was our our largest group. But of course, most people had more than one disease, usually hypertension and diabetes, and the population actually was. Most of them had already had a primary diagnostic that was done in Syria, and they were just coming to have a follow-up medication. So that was the plan of MSF. You know, you give medication, you treat the people, you provide with the primary healthcare for NCDs, but you also provide for specialist care. You also provide for certain interventions that to prevent long-term complications, and that was the idea. Of course, and I'm gonna come back to this on the side of challenges. it's a long-term commitment, right? I believe the average time a refugee spends as a refugee is about 17 years. So if you're trying to set up an NCD program, I mean, you have to think about a long-term commitment. I mean, at least 15, 20 years, right? And this is in the hope that at some point in the future, the Syrian refugee population will be able to go back to their country to a renewed health system, which will be able to take care of them. But of course, concerning the Syrian civil war, it doesn't look hopeful, and I mean, this is just my opinion, of course, but we'll see. I mean, it's been 4 years, and one of the largest and most difficult human crisis we have seen in the new millennium. Jumping back to the NCD program, I'm sorry, I digressed a little bit. One of the things that we were focusing on was the development of human resources, right? Because the idea is you can't create bubbles of attention. You can't just go and intervene and bring your own international, prepared and highly qualified personnel, and then just at some point where the donor interest doesn't align any longer, and you leave a huge bubble of attention. So one of the primary core competencies of the program was to create a qualified and highly developed and trained personnel in the local context. So I was working primarily on creating protocols and creating algorithms and training the first level, the physicians at the first level of care. And I had a team as well with me of nurses that were teaching the nurses that side of the equation. And I was also working with social workers and community health workers in order to kind of delegate some of the responsibility to them, and so as to create a little bit of a stronger outreach program and to not have to rely entirely on consults done at the hospital, but also home care, and we kind of wanted to try to train all the health personnel to be able to deal with this issue. And so part of the approach was this train the trainer approach, and which we were doing with everyone at this level. We were training the physicians, nurses, social workers, and community health workers on train the trainer methods. And we were hoping, and this wasn't done when I was there, but we were hoping to actually have this outreach activity done and have these people go out and continue the training to actually make it a sustainable intervention. Another huge part of the intervention was focused on quality control and rational prescription. When we came, we noticed that the Syrian refugee population was actually pretty used to a highly interventionist, highly aggressive medical care, and the Lebanon physicians were pretty used to it as well. So they were not only for NCDs, but for example, antibiotics. They were just prescribing antibiotics to almost 100% of the patients. I've never seen so many people on their 20s having stents or other, interventions for cardiovascular disease. So this was one of our focus, to try to have a stepwise approach towards health and medical care, and to kind of control the quality and rationalize our resources. Like I was saying, some other things that we were doing were based on kind of strengthening the local structure. So and this kind of mirrors or it was done at the same time as we were doing other activities for the NCD program, but we were strengthening communications lines between local actors and the international ones, and we were helping develop them administrative tools. So one of the things that we found that there was really poor vertical integration of services, and this was due to a highly fragmented system and other things. But we tried to really make a cohesive plan, get the basic administrative functions done, such as a referral system that works, strengthen communication lines, planify with the local actors and international actors to really work with them to get algorithms and protocols that work on the local, to actually have a good patient, a follow-up of the patients, to have an efficient monitoring and surveillance systems that was not in place. And this was some of the activities that we were doing as well as part of the NCD program and the primary healthcare. So moving on to some of the challenges that I noticed in my experience there, was a huge lack of baseline information, and this reflects on some of the limitations that MSF has. So MSF has almost kind of two branches: the operational one, which is MSF, and there's also a kind of a research group, which it's called Epicenter. And what they've been trying to do is really have research as a core competency of the operational function of MSF, something that was usually done by Epicenter. The problem is that there hasn't really been a full kind of commitment to research, to actually getting the full information at the baseline, and this goes back to the difficulty of setting such a program in a humanitarian setting in weak health systems, but also I think a lack of vision from the operational side, and it's a work in progress for MSF. You know, if trying to work with with NCDs, which is an entirely new thing for them, and their core competency is emergencies and dealing with the acute thing, but they haven't really spent much time thinking about the commitment needed for dealing with an NCD population. And I think that baseline information and evidence building is one of those problems. We didn't really know what was the condition for the Lebanese, how vulnerable they were. We didn't know, we still don't know, and the UNHCR doesn't really know how the Syrian refugees are moving. There's a lot of flux. There's people come and go, and there's even though there seems to be certain control, there's a lot there's a huge part of the population that just gets lost. We don't know if they're staying in Syria or staying in Lebanon or coming back and forth, and it's just a little bit confusing at times. One of the other things that I was mentioning is managing patient expectations. So for the Syrian refugees, they were used to having, like I said, a somewhat strong health system. So they were used on going to the doctor in Syria and getting all their medication and a huge battery of laboratory tests and so on, and a lot of practices that are just not possible to actually complete in a humanitarian setting. And so dealing with those expectations was very difficult. So much that even though I believe that we were doing a very effective, a very good quality job, Syrians were expecting much more. So the appearance or the appearance of service and the patient satisfaction was not what we would have hoped for. Likewise, we were actually only focusing on Syrian refugees for the NCD program. Meanwhile, the Lebanon vulnerable people didn't have access to the same medications we were providing to the Syrians, and that became a huge problem, not only for the population, but even for our Lebanese staff, who perceive this as an inequality. And we can talk much more about this. I think that's a very important and interesting subject, but for the sake of time, we're going to move on. The other part is that NCDs, even for the Syrian refugees who were suffering acute complications from them, didn't really stand out as one of their priorities. The priorities were really, one of them, the highest was getting shelter, right, and food. And so, for example, the shelter was just incredibly expensive. I remember going out on outreach activities and finding out that some Syrian refugees were paying upwards of $600 per month on their rent, and it's just an exorbitant amount of money, and almost impossible for them to pay. And some of the other kind of structural things. If you're talking about NCDs, you have to talk about diet. But how much can you actually ask a patient, a refugee, to eat their vegetables and fruits and do exercise when there's really there's no food security for them in the sense of actually healthy food nets, and they don't have access to these kinds of food. They don't have access to a safe neighborhood where they can do exercise. I mean, so most of these things that you would include in an NCD program in a country outside of a humanitarian emergency are just not there, and you have to deal with that. So that's a huge challenge that MSF cannot do alone, right? And the access to medicine was another huge issue, and we had to make certain compromises with the Lebanese government, but you had to adequate your protocols to what was actually available locally. The health system fragmentation was one of the huge challenges. Like I said, there was a huge lack of vertical integration of services. And like I was mentioning, if you want to intervene with NCDs and with refugee populations, you have to talk about a long-term sustainable strategy and approach, which I thought lacked in this approach. So one of the things that we should learn from this is, or try to learn from other experiences to actually deal with NCDs, is, for example, experiences that we have gained from HIV. One of the things that we're actually planning on implement is the polypill treatment, which was seen in the HIV population with some success, and we're planning on doing the same in the refugee population. Other things like regulatory convergence are quite an issue. Like I said, getting local governments to accept the use of certain or other kind of medication it's a problem. So having convergence, at least geographic convergence of regulatory protocols, it's a must. There hasn't been a lot in another one of the challenges. There isn't really integration in humanitarian guides as to how to deal with NCDs. The only real example that I can give that actually just got published January this year is WHO guideline for mental health during the humanitarian interventions guide, which I think is a straight step forward. And some other things that we have to think about are really how to curb these. I mean, we're like I said, we're dealing with a huge amount of refugees and internally displaced populations that are almost unheard of in our lifetime, and so how to mitigate their occurrence and their impact. I think these kinds of strategies have to be dealt with, and we have to think about, if it's going to happen, how do we take care of the refugees or displaced populations, how to take care of, how to better provide for this huge number of people that are migrating and this flux of people, which we can talk more about in the discussion. Another one is, we have to really think about sustainable care and sustainable operational services. We have to focus on building local capacity, of building resiliency, of reducing vulnerability for a myriad of effects, of vulnerability for the systems, from vulnerability from climate change to armed conflict and so on. And we need to work towards better aid, bigger and better aid. One of the things that I really was astonished was that during 2014, the UNHCR only got about a quarter of the resources that they had budgeted for that year, from lack of country donations. So the resources that WHO has to offer and their agencies is really limited, and on the side of NGOs, one of the things that really that we have to push forward are flexible donations, right? So I mean, you have an airport in Nepal, and there's a lot of money going in for that emergency, but it's much more efficient if donors actually provide the resources for overall strategy rather than specific problems. Because once the donor interest is gone, then the action is gone, right? So there's lack of sustainability in this issue. And last but not least is a better global health governance. And for example, we know that there's been quite a lot of success in regulating tobacco, and one of the things that could be done is would be regulating the trade of sugary beverages, of fast foods, and these things. So I will leave this for further discussion, but I think my time is, we should cut down the time. So thank you very much, and thank you everyone. This is it.
Thanks so much, David. That was excellent. And I just wanted to remind any viewers that we have a question and answer box enabled. So please just submit your questions, and you can also tweet them to David or to NCD Action. And maybe I'll start off with a question myself and then open it up with any more to Chris, if she has some, or if we hear from the audience. David, if you can just switch the screen to your photo, then we can see your face while we're speaking. Perfect.
Is that it? Okay.
Yeah, great. So, I mean, you've highlighted this dire need for concerted strategy for NCDs in the humanitarian response, and especially with last week's announcement that we've reached a record-breaking number of refugees worldwide at 59.5 million. You know, we really need to start thinking about the need to care for chronic diseases outside of functioning healthcare systems more, and it's very challenging with the need for long-term care and chronicity. But one stat that I read was that potentially more people had died from preventable chronic illnesses in Syria than from the conflict, due to 60% of the hospitals being destroyed. I'm not sure if that statistic is accurate, but it's staggering. And I mean, another thing that I saw was that 20% or less than 20% of those who require diabetes or cardiovascular medicines actually receive them. And so this lack, where do you think this lack of medicines, or the lack in kicking up the response to deliver these medicines, what are the barriers? What are the things that we can do to address this lack of medicines for NCDs for people in Syria or refugee populations?
Well, I mean, for people in Syria, it's really, it's like you said, it's a very dire situation. For example, we know that in Aleppo, the second largest city in Syria, before the civil war, before the conflict started, there were about 2,500 medical doctors working in there, whereas now only 100 are actually working there. Most of them, they've gone out of the country to Turkey, and mostly to Turkey and Lebanon, and to Jordan. So medication is part of it, but how can you actually deal with this humongous people drain? And so yeah, it's a difficult question to answer, really. There's so many actors playing out right now. You have the Kurds, you have ISIL, you have the government itself, you have the rebels. It's just, and no one is really the priority. Health is not the priority for any of these groups, right? Even the MSF has spoken loudly about actually hospitals being targeted, and health services overall are being targeted by military action, partly due because they use these installations to take cover, because they think, who's going to attack a hospital? But it's a huge issue. And how can you bring medicine to the people living in Syria currently, when even going as a humanitarian agency is very, very dangerous, and then where the borders are heavily militarized, and I'm afraid I don't know how to intervene. I mean, I think the international awareness of Syria has really been subpar. I mean, it was right there up in the news maybe a year ago, but the conflict has aggravated, and we haven't seen any kind of action. There was some action between the U.S. supported the Kurds in an invasion by ISIL and things like this, but we haven't really been focusing on the people, on the Syrian people, and what's more, the millions of refugees living outside. The health systems and the countries surrounding Syria are just not prepared to deal with this massive influx of people. So there needs to be a higher commitment from countries to strengthen whatever safety nets are for the refugees in these countries, and I suppose we have to work step by step. I think the MSF approach is valuable in the sense that you provide medication in the meanwhile, right? Where in the means that while rather the conflict evolves, but there are other things that have to be taken care of, such as shelter for the refugees, which is, like I mentioned, a huge concern, and it just seems that even the UNHCR is not being able to deal with these with this high number of refugees. So I mean, I hate to say that the option is a higher commitment and more resources, but it seems like it is, and definitely one of the things that I want to mention is we require a higher accountability in the NGO arena, and because MSF, I mean, in Lebanon, for example, UNHCR has over 100 different NGOs and organizations working under them and providing certain organization and structure to the health system, providing for the refugees. And the MSF is actually the only one working outside, which provides certain kind of accountability between MSF and UN agencies. But one of the things that I most noticeable, and the things that were creating the most inefficiency, was the lack of coordination in the field and the lack of actual strategic planning between the actors, between not only international actors but with local actors. So I think that's one way to go. But it seems like in the humanitarian experiences that I've had, coordination between actors is always just the biggest problem. It's very difficult because, and one of the main concerns is organizations really don't want to show their numbers, and it's very difficult to show accountability in the field. And I think perhaps that would be one way to go, to actually focus on humanitarian accountability and being providing efficient services, and I suppose that would be what I would say.
I wanted to sort of speak to the challenges maybe that MSF has faced, because I think it's hard for people to remember just how difficult it is to maintain healthcare and health services in a time of conflict. Echoing what Jordan said, the latest numbers released by the UN in general for people displaced by conflict and war, refugees and IDPs, is at almost 60 million. Half of them are children. And if you sort of spread that out across the global population, that means that 1 in every 22 people would be a refugee or an IDP as a result of war and conflict, which I think is a really staggering number. Something I don't think that a lot of people realize is that there are so many challenges faced by humanitarian organizations like MSF and like the ICRC when it comes to delivering care. Not just because the healthcare itself is in danger, doctors getting kidnapped or killed, held for ransom, held as collateral by, the different warring factions, but just the fact that it's so hard to trace the people, especially when they're IDPs. You've got a population, and if they stay within the country, maybe they go to where there's family, maybe they go to where there might be another opportunity or just further away from the conflict. And how do you make sure that that person follows up on their medication, especially when that medication is not readily available? To speak sort of anecdotally, one of the biggest issues, I know that the conflict in Ukraine is in its infancy compared to what's been going on in Syria, but there's a lot of vulnerable populations trapped at the front lines, and a lot of it is an elderly population, and a majority of what they suffer from are NCDs. And because of the damages to the health systems themselves, to the actual structures, the hospitals, the pharmacies, the blockades for delivering medications, as you spoke to, people don't have access to insulin or other diabetes medications they might need, things for cardiovascular disease. So there's just such a burden of challenge that you as physicians and health professionals in times of conflict have to face beyond what people ordinarily associate with the delivery of healthcare in conflict. So major props to MSF for, for doing what you do all the time. I mean, you sort of answered the whole problem of, or gave your ideas on how do we become more accountable. Do you see any other resolution to that other than, more support, better systems? Or I'm also really impressed that MSF has such a focus on sustainability, because that wasn't an association that I made. I always thought of it as just being like emergency medicine, not helping to set up the coming systems or a new system.
Well, I mean, to answer this last comment, I mean, MSF, from what I've seen, there's still quite a lot of debate, and there's still internal struggle as to how to deal with NCDs, right? Mm-hmm. And because definitely the core competency of MSF is dealing with the immediate emergencies, and they are the best at doing so. I think they have some of the most incredible supply lines and just reaction times. But dealing with sustainability is definitely an area where they're pretty new at, but it is an area that is being discussed, and the interventions and the programs, the projects themselves are being shaped to provide with certain sustainability. Like you said, I mean, it's not something that you would usually associate with MSF, but as they're starting to work with NCD programs, I think they're starting to realize that you have to deal with sustainability, and MSF really learns from and takes notice from what it's being said about, health system strengthening and strengthening local capacity, and I think that approach was reflected in my experience, but there's still a lot of way. There's still a long way to go on that sense. Mm-hmm. When it comes to you mentioned before that how to deal with the access to medicine, and that's one of the access the challenges that I mentioned. Mm-hmm. The UN, the IRC, there's no NCD guideline for humanitarian action. If you check out the Sphere guidelines, there's, I think, from 40 pages dealing with medical care and certain pathologies. There's, I think, one page for NCDs. There's just not there hasn't really been an integration of NCDs into humanitarian aid, and partly I think because there's no experience in dealing with it or little experience. Mm-hmm. And I think there's still a lot of room to see what works, what doesn't work. One of my main concerns, for example, and going back to the sustainability, is how can you measure your impact, your performance as MSF here in Lebanon, with this population? I mean, are we talking about incidence of acute complications? Okay, maybe that's the way to go, right? Incidence of acute complications, but how do you deal with that when you have such a flux of people? When you have these IDPs that really they go where they shop around, like and which is understandable. They go to MSF when they can, they go to another agency when they can, and they're shopping around who provides what. So there's very poor follow-up. I think one of our defaulter rate, for example, in our NCD project, was really high. It was almost upwards of 80%. Just people went once and didn't come back, or came back years later. But if you're starting in an NCD program, you really have to take in the long-term approach to your performance. So you won't be able to see. You really can't monitor, or it's difficult to monitor or surveil your activities on a short term. If you have a 1-year action plan and you're going to modify it based on the performance for that year, you don't get that much information. You really have to think on a little bit more term, and the action plans have to be more towards 5 years or more, and the commitment has to be there. And the problem, of course, is it goes back to donor base. And if you have, I'm not sure of the numbers really, but if most of your donations for Syria are marked donations, when the international community, when the media stops giving attention to Syria, the donor base will shift somewhere else, and then what are you going to do, right? Then it's difficult to have long-term projections when your donor base is so dependent on what the media is providing, right? So I'm not sure I answered any of the questions, but
it's a good dialogue. It's a good discussion to have. I think you did.
No, David, you've given a great overview, and I mean, it's such a complex issue, and often a difficult argument to make to prioritize NCD care in this context. And so I think, it's great that MSF is starting to look at these issues, and that others are starting to delve more into some of the challenges in terms of NCD care. And I think over the coming years, I'm hopeful that we'll see more guidelines and strategies, and certainly we should continue to engage in that, and we encourage people within our network to talk to us about this. If you have experience working in a humanitarian setting, or are interested in engaging on this issue in the future, and how to create a strategy moving forward. And a lot of what we talk about on a regular basis is access to medicines for NCDs, and so with a exorbitant prices of these medicines on the global market, how in many settings insulin being around for 100 years and still completely unaffordable, how should patients in conflict situations afford their insulin? So I mean, there's so many things that we can and must do over the coming years in this area in terms of more affordable medicines, access to medicines, and just as one starting point, or maybe not necessarily a priority in the context of talking about the need for shelter, etc. But it was also interesting for you to talk about, the polypill being considered by MSF, and it would be interesting to hear MSF as a vocal advocate for the polypill. To my knowledge, I haven't heard much on that area yet, but I know that the WHO essential medicines list, there were petitions to include polypill on the list as an essential medicine, but it was not added in the most recent version of the list in this May, and just passed. So there's a lot of advocacy that MSF has a strong voice that a lot of people listen to in that area as well. So we are quite pressed for time, but it's been a great discussion, and again, hope that we'll hear a lot more from people in our network. And David, we'd love to have a discussion with you again, and maybe dive a little bit deeper into one of these issues. And I guess one last point I wanted to make was also on the funding, and I mean, just the fact that you pointed at the need for sort of flexible funding. I mean, that's huge, especially since we have such limited global health and aid funding for NCDs as a whole. You know, groups like MSF working and doing these pilot studies with more flexible funding will benefit the larger global health population as well. So, I mean, I think there's a lot of space for a lot more voices in terms of the need for more advocates for the need for more funding for NCDs, just beyond the beyond what we normally see, but you know, expanded to many different situations, also within the humanitarian context. So once again, thanks, David. It was great to have you on. Thanks, Chris, for joining us as well for this great discussion. And again, if you want to share any thoughts, please use the hashtag YPSpeaks, and our Twitter handle is @NCDAction. Thanks for joining us, and we'll talk to you all soon.
Thank you very much, Jordan. Thank you, Chris.
Thank you.
Bye.